See it. Um, so this is a COVID-19 update for spring. What you are seeing on your screen right now is the up-to-date. So back up, let me tell you that tracking went away when COVID-19 was no longer considered a public health emergency. um, a lot of the information that we're getting, where we used to get up-to-date information, there are some lagging statistics. But if you look at this first all, and then to understand, because the tracking has ended, a lot of the numbers and these graphs that you're seeing are significantly underrepresented and underreported. So looking at national COVID admission rates, this particular one ends at the end of February. So this was the most up to date that I could get. And, what you can clearly see is that even though overall admissions to the ER, to the hospitals, have decreased significantly, you're still seeing that of those admissions, our senior population was still impacted and represented. Those ages 70 and up represented most of the cases that had to be admitted, in comparison to all ages and under 60. So our seniors are still being impacted by COVID-19 and is the highest numbers of those who are entering the ER and being hospitalized. The positivity rate for COVID, as you can see, at the beginning of July, there was this uptick of COVID cases that seem to come in pretty early. Once again, these numbers are underreported because you have people testing at home, but they're not necessarily reporting it. But I think, when you look at this overall trend of the height of 2022, when we had all these positive cases, to now 2024, you do see that, we go into these little upticks, and the upticks are usually related to weather changes, knowing that coronavirus tends to be a winter spring type virus. So the numbers, the positivity rates are now significantly going down. And remember, this is as of the end of February. Um, if somebody was to ask me what this overall negative positivity rate is attributed to, it's attributed to two things. It's attributed to the number of people that got the natural infection of COVID-19, as well as vaccines. This data is hospitalization data, and just again showing you the trend. This, shows you that the hospitalizations overall have significantly decreased. You see this slight little uptick in 2024. That was when the cases started to uptick with the new variant, which was XBB. These are deaths. Death rates are always lagging. That is the one thing that is still being reported and tracked. And thank God that we see that the death rate from COVID-19 has significantly dropped. Once again, really contributing to vaccinations, because that's what we know about the vaccine. It is there to prevent moderate to severe illness that would lead to hospitalization, ICU admission, as well as the death rates. People have been saying, well, what's really been the impact of these vaccines? And you're seeing it right here on the graph. This is looking at actually vaccination rates. And that is the biggest challenge. People are, what I want to say, vaccine overload, especially when it comes to the vaccine to against COVID-19. It is, because we are living through the development of this vaccine and the development of how to treat this illness. there was the original vaccines, then you had the boosters, and then for the fall of 2023, they came out with a whole new vaccine. They didn't even want us to call it a booster because they stated that, all our immunity by the fall of 2023 had waned. As you know, the immune response to COVID, to the vaccine and to the natural infection, it decreases and can eventually disappear. So that is why you will see that periodically we had the fall COVID-19 vaccine, and in a slide coming up, they're recommending one now for the spring, especially for that senior population of 65 and over. But as you can see overall, vaccination rates have significantly decreased. And it's across all racial lines. There's not even really, when it comes to the decrease in vaccinations, it's across all, it's like even before, Latinx and African Americans were lagging behind the white population. And then with the rise of the evangelical, basically protests against vaccines and conspiracy theories, the vaccination rates for whites began to decrease. And for a little while, people of color vaccination rates were higher than those of our white counterparts. But now everything has basically leveled out where people are just not getting vaccinated. I pulled the vaccination rates for Pennsylvania. I apologize, this is a little skewed, but you can see, according to Pennsylvania, 74% completed that first primary series where you got 2 Pfizer, 2 or 1 Johnson and Johnson. When it came to the bivalent booster, which was the first set of boosters that came out, that booster rate dropped to 19%. And then, as you go by age groups, you're seeing that ages 5 to 11 in Pennsylvania, their booster rate was 5%. The 18 to 24 age group was at 15%, and 65 and up was at 46%. So you're seeing that the seniors are still accounting for the higher admission rates, but their vaccination rates compared to the other age groups are high, but it's still at 46%, which kind of leaves us in public health as who we begin to target with marketing for this now spring COVID-19 vaccine that's supposed to be on the horizon. This is an overall rate of vaccination in relation to hospitalization. So even though the numbers have declined, you can see that this dark red represents those who are unvaccinated. And when I looked up for this particular graph to see what was considered unvaccinated, was those who never, ever, ever got any COVID-19 vaccine. They didn't get any vaccines. Then you have this little medium color here. Sorry, jumping ahead of you. The median color here, those who completed that first primary series when the vaccines just came out, and then the faded color are those who updated with boosters. As you can see, those who never got vaccinated for COVID-19, their rate of infection and hospitalization remains 3 times as high compared to those who got the primary series and to those who got the booster. Now, if you look at this, you say the vaccine is doing what it said it would do. Once you became vaccinated and you boosted, it prevented you from getting moderate to severe COVID-19. But those who had to be hospitalized were those who were in the completely unvaccinated group. The vaccine update, Um, there is the spring COVID-19 vaccine. Right now, it's really recommended for those 65 and plus those are who are immunocompromised. Um, so, you should be, if you haven't heard already, but you should be hearing, you should be hearing about this uh, spring vaccine that's on the horizon. The prominent variant right now is JN.1. It is a variant that is not as it moves quickly. It moves swiftly. It has become the most widely circulating variant of COVID in the United States. Right now, it's accounting for about 83 to 88% of all the circulating variants as of the end of January. One thing you all should know by now, this virus mutates. It's a cold virus. It was corona was always known as a cold virus, and to date we have no cure for the common cold. The one thing about JN.31, it doesn't really cause severe disease like the novel virus did and the Delta virus did, and the and part of that XBB1. But what it does do is it spreads rapidly, right? It's very, very highly transmissible, meaning it goes from one person quickly. And the one thing about variants, and I always say, when you think about variants, think about a mutation, think about your body. Your body developed defenses against this virus. The virus is, I have to live by any means necessary. So the virus then, whatever defenses that your immune system develop, this virus then says, I got to figure out a way to get around that. And it is smart, and it can mutate, it can change quickly to try to get into to bypass the antibodies and that you've built up against it. So that's what you're seeing. The variant is just, and if you think about, since we started in 2020 with that first novel virus, then we went to Delta, then we came to Omicron, and then Omicron split off into so many different variations. Now we're hitting this JN.1, which they do not believe has anything to do with the Omicron variant that was really prominent last year into the fall of last year. So this one is more transmittable, and it tends to be better at evading and getting around the immune system than the other ones that were circulating. But the thing about JN.1 is that the symptomology is a little bit milder. But once again, symptomology and how you present has so many factors based on age, based on environment, based on if you have any other chronic illnesses at the same time, based on the status of immune system, if you're on medication that makes your immune system lower, the type of environment you may be working in. So, how any particular variant presents, even though I might say it's not as severe as that novel virus, the Delta, or even those beginning strains of Omicron. For somebody who ends up hospitalized, it's severe enough for them. So the thing about it is the main issue that has happened since we met is the CDC now has gone through some guideline changes. I'm going to actually go to the next slide and then come back to that slide. So the thing about this is, and you may have heard this on the news, the new CDC guideline states that those who test positive for COVID no longer need to stay home from work and from school for 5 days. They're going back to this criteria where they're saying, if you are fever free, let's say that fever is one of your symptoms. If you are fever free for 24 hours without using any of the fever reducing medication, Tylenol or whatever, and your symptoms are mild, you can return to work. Understand that some employers may still require you to stay home for 5 days. Kelly, I see your hands raised.
Reverend Lisa, it's Cynthia. Rosemary asked, can children get this new variant?
Right now, they haven't. Just to let you know, they're working it right. They're working that out right now. But right now, the preliminary target audience is going to be those 65 and older. I'm pretty sure that eventually they will bring the young people into it, but their target audience for this spring vaccine right now is 65 because and older, because they're still accounting for more severe cases and more hospitalization and ICU admissions. Any other questions, Cynthia, before I go on? Okay.
No.
Okay. So going back to these guidelines, and what the CDC is saying is that the reason they're revamping their guidelines around isolation and no longer needing to stay home from work and school is because they believe that nationally, we used to talk about herd immunity. And herd immunity simply means that if enough people get vaccinated or get the natural infection and build up antibodies, that we can protect those who are not vaccinated, so what they're saying, the CDC is saying, is that they believe now that there's a level of immunity to the virus, either because of being vaccinated or because so many people have had COVID, that there is this level of immunity that does not warrant this isolation. But like I said, different workplaces and different school systems are still, just because the federal government is still has not yet weighed in on this guideline to mandate anything. Go ahead, Cynthia. Is that the hand raised from before?
I'm sorry. Is the test standard for all variants?
Are we talking about the current COVID? Yeah, because the thing about the test does not test for variants. The test tests for that spike protein, which is on every mutation of that virus, because it is the spike protein. I'm gonna go back to that picture. Let me go back and show you. So it doesn't matter the variant, because the vaccine is against that protein that is present in all of, you see over here, this little spoke that's the spike protein. Though that's what the virus uses to enter our cells. So the vaccines are against that protein, which is on all of the coronavirus. That's kind of like corona means crown, and the virus looks like it's wearing a crown. So it's not variant dependent. It's against that protein. So yes, the test tests for the spike protein, which is present on any variant. Good question. So going back to these guidelines, now the federal government still really has to meet and weigh in on this CDC. I'm making it a guideline. It's kind of like a recommendation. It still has to be looked at, voted upon, and then understand that even if the federal government agrees with the CDC, states still have the ability to either accept what the federal government puts out, or to do what they believe is in the best interest based on the state and their population. And like I said, you have employers, like my employer's like, she doesn't care. If you test positive for COVID, you got to come back to work with a negative test. So, but this is the guidelines that's out there. But know that it's a work in progress. I wanted to let me go back. So part of what the CDC is recommending is that as much as possible that we stay up to date with vaccination. And like I said, I'm focused on COVID-19 tonight, but understanding that flu season, RSV, I mean, we're still in it. And to be honest with you, spring now brings out other viruses. So the pox viruses come out in the spring, chicken pox and different things like that. So the thing is to still be vigilant. Like I said, they are bringing out this spring vaccination against COVID. That's what they're calling it, which is still in the works. But they're still saying, if you can stay up to date with your vaccinations, definitely do not let up on the hygiene. That's, covering, wearing the mask if if you coughing and sneezing, the washing of the hands for 20 seconds. The other thing I want to encourage those of us is you still should be defogging your churches after you've met in person. I'm not talking about the initial industrial type defogging when all the buildings were closed up and we told people and it was a little costly. I'm talking about hopefully those of you who may have purchased one of those portable defoggers, and after your in-person events, whether it's actually your worship service or maybe you have an event in the fellowship hall, you really should be still defogging with the substance that specifically say they're against the flu, RSV, and COVID-19. Okay. Please, if you're in your church and you guys have let up on that, I would really, if you're a pastor, consider it, or maybe if you're a trustee, talk to your pastor, because we still need to disinfect after these gatherings. Um, the other thing is they're recommending, the whole ventilation issue. And it's the same thing for those of you who may be in facilities and churches that may have central air or whatever ventilation type system you have. You really should have it at least inspected once a year. There's stuff that you can put into it that can really help. I went into a sanctuary not too long ago and they had some air purifiers scattered around the fellowship hall and the sanctuary. Little things like that to really work on the air. And not many of us know, and that's not even just for COVID, but many of us may be in buildings that are experiencing, mold and maybe some, other things that can come out the ventilation system. So air purifiers are a good idea. We talk about using it in the home, but I think it's a good idea for our communal spaces in the church. Long COVID. More and more, long COVID is this ever evolving new syndrome, I should say, that we have to as a community really stay up to date on. Now, initially it was 10% of those who have COVID-19 develop long COVID. The latest data that I'm seeing is 7% of Americans. I didn't put it in here. I was like, how could I not put in the percentage right now as they can tease out for African Americans? There's like a range, like the range goes from as low as 13% to as high as 33%. So looking at our communities, all I can tell you is we're being impacted by long COVID more than the 7% of Americans that are reported. The other reason that our numbers and percentages may be underreported is because we are not partaking in the long COVID clinical trials, right? But I do want to tell you that this 7% is for the general population. But when you're looking at us, we're ranging anywhere from 13 to 33%. I always encourage anybody who has long COVID within our communities, Latinx communities, our African American communities, that if there is a clinical trial going on, granted that there, you meet the guidelines and everything, please participate in it because we need that information. We need to know how long COVID is impacting us. The biggest out of the 7% of Americans, the biggest symptoms that seem to be lingering in the population of people infected with COVID-19 is fatigue. And this is an extreme fatigue. This is not, oh, I feel tired. This is an extreme fatigue where getting up is a struggle, where you get up, you go through your days, and by midday, you feel completely exhausted. Difficulty breathing, those who may have had some scarring on their lungs due to the infection. I was looking at a study not too long ago, well, reading a study where they were doing PET scans of like the lowest level of our lung sacs. It's called the air spaces, the alveoli. And they're looking to see how that virus damaged some of those air spaces where the circumference has decreased. That might be leading to this. So you may not have scarring on your x-ray that's causing this difficulty breathing, but those air sacs may have been damaged. Brain fog is the big one. And brain fog is that immediate short-term memory where I'm sitting here talking to you, and if I come back to you and you would say, Dr. Lisa, and you want to, and you just totally forget. It's that immediate short-term memory loss, that brain fog. And in the little bit of data that I seem to be able to pan out, brain fog is one of those symptoms that's impacting our communities a little bit higher than the national average for long COVID. Joint pains, and then you can lose your taste and smell with COVID-19, but this is where the long term is, where now you're going into like 6 months to a year, and either one of these or both of these are still missing, right? Um, so the other thing I had reported that was in some initial studies was that they're seeing that Black women who have had COVID-19 are starting to experience hair loss and alopecia. That is an ongoing study, but like I said, that is a symptom right now that seems to be, I don't want to say unique, but seems to be more prevalent with us, where the hair shaft is thinning, because you got to think about this virus. It hits it once it enters your system, it really causes an inflammation type response in your body, and that inflammation can occur anywhere, and excessive inflammation can damage any type of cell. Cynthia?
Two questions. The first is, what's the long COVID trial website? One of my employees has it, and it's been really tough on her.
Mm-hmm.
And so if you can put that in the chat when you get a
Okay.
chance. And the other one is, I'm suffering from brain fog. Is there a study that I can join?
Okay, so the best thing to do is, number one, if you're suffering from brain fog and your doctor has that ruled everything else out and say, okay, this may be due to COVID-19, you need to see your neurologist, because a lot of the clinical trials are coming through neurology. You may be going to your primary care doctor, but if you have brain fog, you should be referred to a neurologist. The neurologist is the specialist in the brain, right? That works with the brain. Now, your neurologist, and sometimes the hospital that they're affiliated with might be running a clinical trial. So the first thing you need to do is, if your primary care is saying, yeah, you have brain fog and it's due to COVID, then hopefully if they send you to a neurologist, but if they didn't, you ask, can I now go see a neurologist? You get to neurology, and neurology now, you say, are there any clinical trials that I can be a part of because there's a huge, a lot of criteria for these clinical trials. Is there clinical trials that I qualify for? I would like to, see if I qualify for that clinical trial. Um, so you now have doctors who are literally specializing now in long COVID because it's like a new area. So you can ask, are there any doctors in the facility or in the hospital that's affiliated that are working on long COVID? And I know like our New York Health and Hospitals, they have a long COVID center type clinic. And through that clinic, they put different people into clinical trials. So the best route is to start with your doctor. And as I tell you, if you have any of these symptoms, and I see your hand raised, Sister Muriel, give me a second. If you're experiencing difficulty breathing and it's come to the conclusion that it's due to COVID, you should be seeing a pulmonologist, the lung specialist, brain fog, the neurologist, joint pain, rheumatologist, right? If you're dealing with the loss of taste and smell, ENT, ear, nose, throat needs to get involved in that. So your takeaway is your primary care doctor is the first line. But once they have determined that there's an ongoing symptom that is due to COVID, diabetes, there's COVID-induced diabetes, right? Then you should be going. Your next step is for them to send you to the specialist that deals with whatever that symptom is. Sister Muriel?
I was just going to ask Dr. Lisa, how does one distinguish between just say lapses in memory that you get with general aging versus long COVID? That's question number one. Question number two, how do you feel as a physician about the COVID guidelines, the CDC guidelines?
Okay, so starting with number two first. To be honest with you, I really don't believe the United States is at herd immunity, meaning that 80% of this population has developed, because think about what we're saying. If you think about what we're saying, it kind of doesn't make sense. We're saying that immunity to COVID decreases and wanes, right? So when are we ever 80% as a population immune? Because if I'm thinking about it, right, some are going to be immune because I might have COVID-19, the natural infection, and I'm immune for about 6 months out. Okay, I got a vaccine, but I didn't get a booster, so I'm not immune anymore. I'm not considered immune by their guidelines. So my question would be, when are we really 80% as a nation? Have we achieved herd immunity? And the reason I say that is because I'm skeptical. Therefore, basing your new guidelines saying because we have this immunity, we can go back to work. I'm concerned about that. I'm concerned about that as someone scientifically trying to understand it. And I'm also concerned about it from someone interacting with populations. If somebody has COVID at my job, stay home.
Exactly.
So, it's hard for me to kind of reconcile these guidelines based on immunity. Okay, how do you distinguish a forgetfulness from a brain fog? Really, it has to do with duration and frequency. And one of the things the neurologist will have you do is create sort of like a memory diary, and you bring it with you. So if I'm going 2 weeks and then I have a lapse, I just forget something. Okay. But if it is something where it's more frequent and somebody speaks to me now and like 2, 3 minutes later, I can't really piece together what they said or pull it to my thing, that's a little different than forgetfulness. But it usually starts with a memory diary, and the neurologist starts to look for patterns. And if it's more frequent, then they'll say, okay, this is a little bit more than just forgetfulness.
Okay. If I can make a couple of comments, I heard a physician say that he developed the sniffles, decided to take a rapid at-home COVID test, which was positive, did a PCR test that was also positive. He said there's no way on earth he would subject his patients to that, go back to work. So he did not.
Mhm.
Is I got a call from a friend this morning. Her 13-year-old niece, asthmatic, was in Children's Hospital, died last night from COVID. Her school
Mhm.
has an outbreak and did nothing.
Mhm. And like I said, the danger zone is now they could take it or leave it. School systems can, and like I said, and this is still being, this has not, these new guidelines is just the CDC came out with that. The federal government still hasn't come to a decision. States haven't come to a decision. But I trust and believe that I know parent groups, and like I said, my employer's like, you're staying home. I don't care what the guideline says. Um, it's going to be interesting to see how it pans out.
Absolutely. Thank you.
Mm-hmm. Um, I'm putting one, so I'm putting also in here, one of the biggest, and I love the drug companies, it's like a love-hate relationship, but a lot of Pfizer does a lot of clinical trials because, Pfizer is really trying, if they can understand long COVID, and the idea is always to then develop, a medication or something. Um, the other places, I'm just putting some of the websites that you can go to find out about clinical trials. But really, really, the one that I really like is the National Institutes of Health. But understanding that to get to any of these trials, you have to first go through um, a physician, because they will know if you meet the criteria. And that's it for me. If anyone has any other questions.
Reverend Dr.
Mhm.
Lisa Williamson, we really appreciate you. If anybody has any questions while you're getting them together, you can
Mhm.
feel free to mute. I put a link in the chat. It is
Mhm.
a survey we're asking everyone to fill out. We are also asking everyone to please leave your name and your email address. Not only for this survey, which is one of the grants of the International Health Commission, but also so that as we get updates, we can make sure and share them with you. Thank you.
Can you
I-
put the email back in because I was late getting on? Please.
The
And
email or the link
go
to
ahead.
The sign
link.
up one.
Okay, Reverend Bragman, is sign up for what? Exactly.
I thought you said you had to, they were doing that you have a link for
Oh,
us to say we're on the call,
I
no?
did. I just put it in. I'll put it in again.
Thank you.
You just need to put your name and email and fill out. Hold on one second.
The other things I want to say, the push right now, with the people always ask me about mask or no mask, right? And now really masking has become a personal preference. But what I'm realizing is now when people are masked, people tend to question, like, if you have a chronic illness, if you're immunocompromised, whatever your reason is to mask, please do not be intimidated, because now I'm seeing that shift, right? When everybody had to mask, it was like, okay, but now that masking has really become optional. And when you wear a mask now, sometimes you might get a sideways look. But if you have a condition, especially if you're what I call a repeat, meaning you've had COVID now more than once, more than twice. I know people that are going on their fourth time, right, of being infected with COVID. You know, when you come to large gatherings or maybe really public places, you need to wear a mask. You really need to wear a mask, and do not be intimidated because the majority of the other folks are not wearing a mask, right? A lot of times for those of us who are AME, when I go to Philadelphia, you know, and somebody rolls in with 300 people, trust your bet your bottom dollar I'm wearing a mask, right? Because now we're in a tightly packed room, ventilated, not really sure about the ventilation system. So I just want to say, you know, don't shy away from wearing your mask if you believe you need to wear one. Because I've had, you know, I'll people come up to me and say, you know, Reverend Lisa, I had my mask on and I took it off because everybody else had their mask. If you feel the need to wear your mask, wear your mask.
Dr. Lisa, it's so hard to get people to understand that. You tell them no and respect your own risk. Um,
Mm-hmm.
do it like you said, they get intimidated by it.
Mm-hmm. Mm-hmm.
Someone said to me not long ago, "Oh, I finally got my sense of taste and smell." And I said, "When did you lose it?" And she said, "About 6 or 8 months ago." And she never took a COVID test, didn't know whether or not she had COVID. Obviously, she did have COVID at some point. But I think a lot of people don't know that they're experiencing long COVID symptoms.
Right. And that's really the educational piece, right? So all of you that belong to any sort of church or any organization, you know, you know me, the church is still relevant. I don't care what anyone says. And one of the main thing is this access to information, right? So I encourage all of you to find somebody to come in and talk about long COVID, right? And you know, it's just one slide, but literally I can do an hour on long COVID. Like I said, the NIH has these ongoing studies and trials, and they publish their results periodically. And I'm very fascinated by long COVID because I know that our community is being impacted by it higher than the national average, right? And it's a new area, and we need to participate in it and to get the information out there, because we are a community where we'll try to endure certain symptoms until it gets to a point, and then, oh, I'll go to the doctor. And this is new. You know, your hair might be thinning and falling out, and you might attribute it to something else, you know. But if you've had long COVID, I would behoove you to see a dermatologist, to go to your primary care and to get to the dermatologist, and you know, to see is rule out thyroid and all that other stuff. Is this part of COVID? And now they're looking for trials, because like I said, the one trial that they did is showing that it's prominent in African American women. And don't just say it's, you know, because I'm in menopause.
Mhm.
Dr. Williams, can I ask a question on that too?
Sister Yolanda?
Yes, and Pastor, you're so right. But in schools, the scary part is they're giving kids home COVID tests.
Mm-hmm.
I know for me, I test constantly at home, but I tested home originally when I caught COVID. I called my doctor.
Mm-hmm.
Immediately, she wrote it because she keeps statistics. She's like you. She keeps statistics. So she warns us, and see, this is something too, a conversation that even if you test home, you tell your doctor, see if your doctor keeps the pattern of her patients that may have gotten it. You get what I'm saying?
Mm-hmm.
Report it. That Paxlovid worked for me,
Right.
but I suffer from it restricted my pulmonary vessels because I caught COVID and RSV.
Mm-hmm.
And even though COVID looks like it's dipping, RSV is rising. So the cases of death, they're saying is RSV. And we don't really know if it's really RSV or if it's COVID because they're centering on the RSV now. They don't want to look too much at the COVID thing. You get what I'm saying? So you have to be vigilant. And I'm grateful, Pastor, because in our church, she makes us wear masks. We have to separate when we sit. And Pastor's very much on us about this stuff. So be vigilant. Even if you test at home and it's positive, tell your healthcare provider immediately. Don't just be like, oh, I got it. Oh, I know what to do. Don't do that. Right. Because in our community, it's so much underreported. I know where I live because people think, oh, I tested home. I don't have to do nothing. I'm fine. It's bull.
Right.
Okay. And one of my daughters, she's correction. She caught it 5 times. This stuff is real.
Yeah. I go to the jail once a week, so I tend, to test for COVID a little bit more than other people, but definitely it's about staying vigilant, it's about having the education. And if you're the sort of person, because I know medical professionals sometimes can be intimidating, take someone with you or say, hey, do you mind if I record this? Because a lot of time we'll walk out of the doctor's office and not really fully understand, or maybe we, forgot the question then and there. So, so either take somebody with you to help you advocate, or just hit record and then you bring it home and maybe somebody else listens to it and helps you to figure out what's going on. Because unfortunately, sometimes if we don't ask the follow-up question, we don't, they won't tell us, But clinical trials, that's my big, people say, I don't want to be a guinea pig, but it's an understanding with a clinical trial, especially if they're trying some type of intervention. You may be in the intervention group or you may be in the non-intervention group, but we need both, right? And I don't even want to hear about Tuskegee, so Tuskegee had nothing to do with medication being given. The medication was withheld completely, but we really have to, and every church here, like I said, if you could, most health departments have a speakers bureau where you could get people to come and speak to your congregation either on Zoom or on site for free. And say, hey, I need somebody to come and teach us about this long COVID. You can still go online. They still have some free supplies of the at-home tests. So you could still go online and get some free tests. I did hear that they still have some supplies left. If you ordered it already, you can't get a second batch, but they do still.
Also, Reverend Lisa, most of the city health centers have plenty of free tests.
Yeah.
And they're just not advertising it, but if you walk in there, they'll give you as many as you want.
Yeah. Yeah. And your local, always touch base. As I always say, for every presentation I do, every church should be connected to their local health department. Find out who the community officer is at the health department and get your church's name on it. Because when they get stuff, even grants and stuff, they reach out to those who are on their lists, right? And you could get gloves, you could, whatever, you could get tests. So make sure as a church that you register with your local health department or a local hospital, city hospital. Yes, Sister Francetta.
Hi, everybody. So I was doing the survey, and the answer I kept finding myself answer to about disparities and equity and all of that was access, access, access. So yeah, I'm glad Reverend Lisa was talking about how we can access those COVID tests, because a few weeks ago when I work in the hospital, I had some kind of stomach virus. I was in the emergency room and I asked the doctor, can he test me for COVID? And he said, why? And I said, because I want to know if I have COVID, you know. But
Mhm.
so they're not really pushing those tests like, anymore. And access is a real big problem. But through the church, we have a lot of access. We have a lot of access to different things like this workshop, these things like this. We bring it to our communities so that so people can know even that there is such a thing as long COVID.
Mhm.
And then it's about just being kind and nice and not going outside if you're diagnosed with it. You don't have to. That's your choice. People have a choice whether if so many people is diagnosed and they're not being cautious at all. And it's
Mm.
sad to hear about the child who died last night.
And I do,
Mhm.
I can't speak for other states,
Mhm.
but one of my growing concerns is that with the increase of asylum seekers and migrants, I know that within you have a large population of individuals coming in that may not be up to date with their vaccinations. And I know certain school systems were giving grace periods. One school system out here gave up to 10 months for to get everybody immunized. So now we're seeing, that's why I'm saying with these new guidelines, I'm very concerned because immunity, now we have large influx of individuals who are not coming from countries that had strict vaccination guidelines. And we now have to get them vaccinated, get them and their children vaccinated. So, and you're talking about COVID, which we have availability, but a lot of these other countries didn't have the availability and access to the COVID-19 vaccine that we did. So that's another emerging health burden on the system, especially when it comes to vaccination, because you have children that are in school that are not fully vaccinated because now the system has to figure out, okay, we got to give them the vaccine. So that's a cost now, right? And it's all these burgeoning issues that the healthcare system has to figure out. The nation can't even figure it out, but we have to figure it out, especially when it comes to children being admitted to school and they're being given grace periods to be vaccinating. I see a hand raised.
Reverend Lisa, it's Cynthia again. I
Mhm.
just want to say, and with the influx of the immigrants and trying to place them, a lot of kids, I know when the measles was really big in January and February, it was
Mhm.
because the kids weren't being tested, or they were, but the parents had to go to work. So they
Right.
sent those kids on to daycare and on to
Mhm.
school because they had to go to work. They needed to feed their kids and they didn't understand that they were
Mhm.
just spreading it. Their thought was, I have to go to work. So
Right.
you've got to go to daycare or you've got to go to school.
Right.
And like you said, they don't have that understanding or didn't have that sense of urgency about COVID that
Mhm.
we had even 3 years ago. So you can't make them understand it now that everything's relaxed.
Right. Sister Yolanda.
Okay, this may sound silly because all my kids are 30 and above, but they no longer, I know when I went to school, it was mandatory that you had mumps, measles, rubella, tetanus,
Mhm.
whatever.
Mhm.
They're not making them get inoculated before allowing them to
Well,
enter the public school system.
they do have to, but there's such a backlog and such large numbers that some of the school system had to give small grace periods to say, we will allow your child to matriculate, right? And then they have X amount of times to get vaccinated up to, our US standards. It's not
And
like they're coming with nothing, but where we may say you need 5 or 4 vaccines against whooping cough pertussis, they may have 1 or 2.
Okay,
You
so they
know,
don't have the little health department card that you needed to register your child with
well,
anymore.
like I'm saying, they're getting some of the school systems are giving them grace periods because they're trying to get all these kids and adults up to things. So it's not saying that they don't plan on do it, but this is sort of how the system had to adapt. And it's
Right.
a concerning adaptation because, like Sister Cynthia said, you know, you're hearing outbreaks of measles, you know, stuff that we thought we had under control. And like I always tell people, modern doctors like myself, we would probably delay to diagnose measles because when we trained, we didn't see it. We saw it in a textbook, but we didn't necessarily see it actually, you know, but and measles is something that spreads quickly, but once again, it's the system, you know, the system is trying to adapt and adjust to this huge influx of individuals.
And Reverend Lisa, also, a lot of children are being homeschooled now.
Right.
Are
So
being
there goes
schooled
the
in
other
charter
piece.
school, but then they go to camps or they go to the
Right.
playground and play or play in the street with the
Right.
other kids. And so the kids that are in public school may be vaccinated or on a list to get it. But
Mhm.
these other kids are homeschooled and they're not
Right.
getting it at all because their parents don't want them to get it, but they're all playing together.
And
So
just so you remind me, Cynthia, one of the legislation that's out there that we have to think about is, you know, schools and other systems to be waived from vaccines, you really needed to belong to one of those denominations that don't use products, Jehovah Witness, Seventh-day Adventist. We have this whole lobbying now up in Washington where parents want a law saying that a parent, that you don't need to have a religious exemption, that if a parent doesn't want their child to be vaccinated, that is something that should be honored. Now, it's been knocked down several times, but they're lobbying hard for that. And, you know, my prayer is that it doesn't make it as a law because now, because you have this anti-vax campaign going on, you know, and to say now a parent can just say, I don't want to have my kids vaccinated, that can lead to a huge ripple effect going down. Like I said, some of the states and Congress have been knocking it down, but it's a platform for the Republican Party, parental waivers for vaccines. So keep your eyes and ears out for that one.
Wow.
And as
Scary.
churches, we need to write the letter campaigns and tell our folks no, you know? All right. I think my
I
time.
just say it's scary.
Mm-hmm. Yeah.
yes.
But the church, this healthcare and the church is a ministry that really, every church should be doing some form of education around something, whether it's to come on to something like this or, you know, doesn't matter your size. You can partner with another church that's doing something. You know, the International Health Commission is always rolling out different webinars and presentations. So, you know, we need to get the word out there to our folks, especially about long COVID.
Yeah, Dr. Lisa, one of the challenges I'm seeing in Harrisburg is that there's amongst the leaders, clergy and others, there's this apathy. People just don't think it.
Mm-hmm.
And so, you know, I feel sometimes like a lone wolf crying out,
Mm-hmm.
and everybody just looking at me as like, oh, that's all he ever talks about.
Mm-hmm.
But at the end of the day, I'm going to keep talking about it, and we're going to keep doing vaccinations. But like we had a clinic just the other day, and the pharmacist said to me, you know, when you only get a few people coming to get vaccinated, she said that's actually impressive because
Mm-hmm.
in some of these areas out here, nobody is getting vaccinated.
Right.
And people just don't care. They think it's gone, it's not an issue. And
Mm-hmm.
so just because they don't see everybody dying like they were at the beginning, when we first started and we didn't have a vaccine and when the vaccine came out, I had a line of people going around the building who couldn't get vaccinated because we ran out of shots. But now I can't even get 2 of them in the door.
Yeah,
I
but
get
like
them
you
in the street.
said, keep doing it because that's the prophets, right? They would keep speaking whether the people listened or not, you know,
Yeah.
because that one person that gets that vaccine, you probably saved them a whole lot of healthcare costs.
But thankfully, my members are getting it because whenever we had these clinics, if nobody else gets them, my members sign up.
There you go.
So at least
There
I
you
know we
go.
getting pretty well protected at our church. But it's just sad I can't always convince my colleagues that it's as
Yeah.
urgent enough of an issue to start doing something about it. And my prayer is that they will get it at some point and not wait until folks start dying in their church before they get it.
Right. Sometimes, you know, if it's not close to home, but when it hits close to home, then folks' eyes open up all of a sudden.
You know, I would just like to thank the gentleman who spoke, who said he's going to keep going, because that was confirmation to me. At our church, we have a health commission, local health commission, of which I'm the president. And at the top of the service, I give a 5 to 10 minute talk on whatever is relevant. This past Sunday, I talked about COVID, the change in the guidelines, suggested best guidelines, and also the spring vaccine, the booster that's coming up. And mean age of our church population, I believe, is 79. So we should be
Yeah.
this. But as just before I started to speak, someone must have come on to Zoom. And what I heard was, oh, they tell you church starts at 10 o'clock and I come on and this is what I get. This
But
is what,
keep, you know, keep doing it. Keep
yeah.
pressing.
So
Keep pressing.
that was confirmation for me. And I thank you. I thank you for that. And I have to give a shout out to AMEAVE. They're doing a fantastic job with information access. I can't say enough about AMEAVE and what they're doing.
Thank you. I think our time is fully spent.
Thank you so much, Dr.
You're
Lee.
welcome. Sister
Dr.
Cynthia,
Lisa,
you still on?
Yes, we just want to
Okay.
thank you again, and we appreciate all that you do, not only for your career, but for your Zion, and to keep us all informed and updated. Can you pray us out?
Absolutely. And Calvary, we have Bible study right after this. Let us pray. Gracious and everlasting God, we thank you. I just thank you, Heavenly Father, first and foremost, for AMEAVE. I thank you for all who find it not robbery to take up their time to bring information, to give us resources, dear God, to continue to not allow our people to perish because of lack of knowledge. I thank you, Heavenly Father, for every prophetic mission and voice in the vineyard that is continuing to stay vigilant, that is continuing to realize that we are a people that still have many challenges ahead, but we do know the God that we serve, and we thank you for every gifting that he brings. And we just say thank you for this session tonight, and that if one life is saved, if one life, it's enough for us. In Jesus' precious name, amen.
Amen.
Amen, everyone. Have a good evening.
Good night, everyone.
Good night. Thank you.